Okay, next, our videographer Gabe has asked me to look at a video from a television show called House, which I don't watch. So let's see what this is about here. Tell you if it's real or not.
Okay then, I'm ordering a head CT.
No, I don't have a headache. I'm not dizzy.
Eddie, I gotta get back.
You gotta stay here. We'll straighten out that mess with Marco tomorrow. Let the doc do his job.
Actually, stitching you up is really the ER doc's job.
That's true. As an emergency medicine doctor, gave a lot of sutures.
Not that you care about that. So how did this happen? Yeah, you're right. It's a stupid question. The answer is kind of obvious. Those scrapes on your hands means you didn't try to break your fall, means either out cold or totally disoriented when you went down. No sign of trauma other than the cut means no one hit you in the head. Powder burn on your jacket sleeve means someone shot a gun.
All right, Eddie. Come on, let's go.
I don't care what you guys are into. If you don't get this checked out, it'll happen again.
Not reality. So this started off very realistic, which is the doctor was suturing up the patient and was talking about getting a head CT scan. Anytime that there's head trauma that's significant enough to cause a laceration, or if there's an underlying contusion, we don't get to see that there, that's where there's maybe a collection of blood underneath the skin. It suggests a pretty significant impact. And what we worry about is that inside your skull, the brain moves kind of like Jell-O moves. If you've seen Jell-O, that if you shake it and it gets like a little fracture line through it, your brain can get that as well. So it's normal when someone has pretty significant head trauma that you're gonna get a head CT scan to make sure that the brain is okay. Again, does no good to close up an outside wound and send somebody out with blood on their brain. That part was very realistic. The other thing that was very realistic is we had a couple characters here in this scene that really aren't talking much about the story and why they're there and what happened. That happens a lot too. We've had literally people come in with gunshot wounds through their legs and they're like, no, I don't know what happened. Or they tell you something that doesn't make any sense. I was at a park and I just got hit. They have nothing else to say. That part is true. People are very tight-lipped because they don't want to get in trouble. Here's where it became unrealistic. The minute that something like this comes into the emergency department, where there's signs of unknown trauma, it could be domestic violence related, or particularly in this case, gunpowder on his arm. When there's a story clearly not being told, the police get involved. The hospital notifies the police. The reason is that frequently there are police calls going on at the same time where they're looking for a particular suspect, or something's gone on and they're looking for a clue because two people ran from the scene. This could be the two. So the hospital is normally already coordinated with the police department to tell them, we have something going on here that, have you anything on your end you're hearing? And here, it looks like this doctor is gonna let him just walk out of the emergency department or out of this room, and that is unrealistic. That would not occur.
Cool. 32-year-old man recently developed loud noise-induced.
Unrealistic. If that was meant to suggest that a person with head trauma would suddenly pass out because of a loud whack noise across the bed, I had to relook at that to see if there was like something in the cane that he actually got hit with. Very confusing about that. There's nothing that you would do. First of all, as a physician, if you could have someone pass out like that, you wouldn't. Because it's highly likely that when they passed out and hit the floor, they would injure themselves worse. So you wouldn't do that if you meant it. What he was doing that for, I don't know. If anything, that might incite someone who'd just been involved in a violent event to become violent with you in the room. Makes no sense at all.
CT was clean, no internal bleeding, no edema. Everything else is in the file. Cameron, get your hair in the course.
Reality, and here's why you have to watch the whole scene before you talk too much, I guess. So this is loud noise-induced vertigo. Now, again, unrealistic that a doctor would diagnose this by making the loud noise and watching the patient pass out. Why? He just placed the patient at substantial risk. Anybody who falls from standing stands a very high likelihood of suffering severe injury. You would never do that to diagnose someone with this loud noise vertigo. Now, does this exist? Yes, it does. You may have heard of the fainting goats that are out there that you can shout at and the goat tips over and faints. What happens is the goat's not actually faking, and neither is someone who suffers from a condition like this. We have a neurologic system that basically controls our blood vessels. And what happens is that we can get what we call vasovagal type events, where a particular stimulus causes the neurologic system to relax, which causes the blood vessels to relax, and then all the blood leaves and flows down to a dependent area. Dependent, I mean downhill. So if a patient's standing up and they have an episode where their blood vessels suddenly relax, all the blood will go downstream. That means down into their abdomen, their chest, their legs, their pelvis. When that happens, there's no blood in the brain. When there's no blood in the brain, you pass out. So yes, it's possible to have a condition that would result in syncope or fainting. And it looks like that's what this patient has. Very unique. Now let's see. Looks like there's about to be a teaching episode here when I stop this on this. Let's see.
You want to get your hair in the divorce?
This guy strained his back 3 years ago, and that's it. All the rest of these pages are blank.
Yes, he won't tell us anything. Understandable, since he's a drug dealer.
So he's dangerous and withholding, which you find irresistible. But guys like that, they never call.
He actually said he was a drug dealer?
Not out loud, but he was wearing a solid gold Patek Philippe. His friend had a Rolex. Their phones were prepaid burners. They could toss them as soon as they're done.
It doesn't matter if this guy's a drug dealer or not. Noise-induced vertigo means ear or brain. Head CT was clean, so I'm thinking acoustic neuroma. We need to do an ABR to test his hearing.
Acoustic neuroma fits. So does lidocaine toxicity, or benzocaine. Depends what he's cutting the coke with.
So now he's not just a drug dealer, he's a cocaine dealer.
He seemed peppy. You test his ears, I'm gonna go test his cocaine.
So these are some of the most difficult patients. One, a difficult condition to diagnose, and syncope or fainting is difficult to diagnose. Number two, a confounding variable. He comes in with a head injury, with a laceration you're suturing up. So is there an underlying injury there? Number three, an external substance that's involved. Now, it sounds like they've made some assumptions here of drug dealing, but assuming that that's true to this point, drugs, alcohol, even medications, they really confound or confuse or make a simple situation more complex. So you can see here now the factors stacking up, and that appears to be what he's testing these residents on. I've also heard him talk about what they're cutting the cocaine with. He suggested procaine, I think he said. There are certain substances that you cut up drugs with frequently that absolutely have effects. One of the most recent we've been seeing is a lot of things being cut up with fentanyl, of course, an opiate, and the devastating effects that's had. So what things are cut up with or mixed in with are also another confounding variable. So this part of the scene is very real, and also I can tell you this is exactly what attendings quiz residents on, or things just like this. What is that differential diagnosis? What are the variety of things we should be thinking about?
You think this guy's just gonna hand over a briefcase full of illegal drugs because you ask nicely?
I hope not.
You're gonna hear a series of clicks and hisses. Sensors measure electronic activity to your auditory nerve.
How long is this gonna take?
An hour, maybe an hour and a half. Or you could walk away with a tumor in your ear. Guy's probably late to his stabbing.
Impedances look good. Starting at 13 clicks per second at 50 decibels.
So what they've just tested for here with the clips on the ear and on the forehead, and they're looking for this acoustic neuroma. What this is that in the inner ear, which of course is associated with balance, can be associated with various causes of syncope, they're looking at this nerve. And along this nerve, you can grow a kind of a sheath of a tumor around it, basically a tumor that goes around a nerve. These acoustic neuromas can cause things like that, and so what you do is they send various auditory signals down the nerve. It's supposed to be picked up by the ear, and if you have one of these tumors wrapped around that nerve, the signal will transmit differently down the one where the tumor is versus the other one. That's what they're testing for. That's realistic.
13's middle name is Beauregard? Wave 3 latency is 3.8.
Slightly delayed, but nothing significant. That's what sticks out to you? House is clearly screwing with us. It's a fake pay stub.
Looks real to me.
There's no way she makes that much money.
I make that much money. And apparently you don't.
Uh-oh, new scene. Let's see what's happening here.
Pulse is bounding.
The airway's clear. Need a crash guard in here.
It's gotta be his blood pressure. We need to get it down before he strokes out.
At least we know his ears are okay.
Good patient on vasodilators got his hypertension under control.
He got worse here at the hospital, means thug life probably isn't what's making him sick.
Which means we can stop the bloodhound gang.
Let's stop here for just a second, because they're going to probably go back to that scene where you saw this person having this this shaking episode here. I think it was the same patient. I just got a quick glance. I can't tell if it's the gentleman who was having the testing done who started to have the shaking, but I assume it was. It looked like he was in the seizure. You can see that is kind of the position he was posturing in, shaking. Seizures don't look exactly like that, but it's fairly close, fairly realistic. And now this is getting deeper on this patient as to what's going on. Now, when you can't get a patient to stop seizing, that's called status epilepticus. Most seizures last a limited duration and they'll stop on their own. They'll end. After they end, there's kind of a post-ictal phase where the patient is just out of it. They're just exhausted. When people go into status epilepticus, they continue to seize and they continue to seize and they continue to seize until you stop it. Now, there are only a few ways to stop these seizures. Most of the time, they involve medications like phenobarbital. We'll see if anything like that comes up. Sometimes after you stop the seizure, then a paralytic. And so they'll paralyze the patient and then intubate them to breathe for them. When that happens, when someone seizes and they've had this head trauma, now you heard earlier that there was a head CT. It sounds like it may have been negative, but remember that sometimes there's a bleed after the initial scan. So there'll be a scan that's done so quickly after the injury, there's no bleeding, and then the bleed develops. So there's a chance here in this case, this could be a delayed bleed. This could be a person who suffers a seizure disorder, actually, or a variety of other conditions. Let's see what happens.
Go back to being doctors.
But we're doctors all the time. It's so boring. Fine.
Could be sick sinus syndrome.
No chest pain, shortness of breath, brain aneurysm secondary to polycystic kidney disease.
Normal urinalysis, kidneys impalpable.
Okay, unrealistic. So the conditions they're talking about, polycystic kidney disease, for example. Polycystic kidney disease is where we have kidneys, they look kind of like very large kidney beans. The kidneys sometimes develop cysts in them. In patients who have polycystic kidney disease, they usually have known it for years. This is someone who's obviously not young. They often have hypertension, so they come in with a history of high blood pressure. I didn't hear anything about that early on. Although now, during this resuscitation, there's been some mention of high blood pressure, but it wasn't part of some sort of past history. It's doesn't quite fit. But then the real red flag here to them just decorating up medicine is here you hear, and you can't palpate it. Okay, so the kidneys are retroperitoneal. That means that where they're located in our torso, they're actually sandwiched in between the posterior spinous muscles, sometimes just underneath the rib cage itself with a layer of muscles, and they have another layer of tissue on the other side of them, very thick, dense tissue. They're kind of in their own little cavity. It is almost impossible to palpate a kidney and feel it itself, much less tell if it had any sort of cysts on it. The cysts, you would never be able to feel any sort of polycystic kidney disease through palpation. So that's decorative Hollywood here. Let's see what else they say.
I thought I'd give myself a little treat. What if it's not his brain, but it's on the way to his brain? Carotid stenosis.
Get an ultrasound of his carotids. See if his arteries are clogged.
This is accurate. The carotid arteries run up the neck here. They come off of so there's the heart, the aorta comes over. That's where all the blood obviously is pumped out through the biggest vessel. The carotid arteries come up, and one of them actually comes off of a subclavian, but they both come up from that area without getting too technical here, and come up through the neck. And that's what we frequently palpate here. Interestingly, here they've said, check his carotids. They also should check his vertebral arteries. So there are also vessels that come up from the posterior aspect, not front, but the back, and they go to the back of the brain, kind of the cerebellum area. If you have lack of blood flow to the brain, you can get these passing out events. You can get these from plaques that block them, narrowing of them. Even sometimes structurally, people will have muscles or bones or different things, even a tumor that obstructs one of them. Any of these things that could cause a compromised blood flow to his brain could result in some of these passing out problems at this point, which is what we know it to be. And so that's realistic. To study his carotids. Hopefully they add also his vertebrals to this study.
Ultrasound showed no narrowing or obstruction in the patient's carotid.
Not that he's worried, keeps asking when he can leave.
Now, I only wish I could get results back this quickly in the hospital. So this is unrealistic so far. I'm sure for television's sake, they have to do it this way. And any of you know who've been to the hospital, this would not happen this fast.
You bugged his room?
Our patient sleeps in the building where they keep their stash. Eventually, he'll say something that gives away where that is.
and we'll find out what's making him sick.
But we ruled out environmental causes.
You ruled out environmental causes.
And you pretended to agree just so we'd take him out of his room so you could plant the bug.
Carotid stenosis was a decent idea, but an even decenter idea is that he's got toxins stored in his body.
Okay, unrealistic. I've never seen a patient's room bugged. We can't invade people's privacy that way by bugging them, and we certainly don't do it in the hospital to figure out what's happening. The other thing here that's false so far, they said we've ruled out environmental toxins. I don't know where that occurred unless maybe I was talking to you during that, but I didn't see much at all for rule out of environmental toxins. So I guess we just have to assume that they've run complete tox screens on him, they've been ruled out, but House here thinks that it's maybe some other strange toxin.
Burns makes him sicker.
If we're going with toxic exposure, we should just start testing for the most likely suspects.
Bug's a better idea than blindly running tests for days.
Tell him it'll take weeks. It'll be faster.
What do you mean, weeks?
These tests take time. There are a lot of possibilities.
No, but I can't sit here this long. I got things I gotta take care of.
You're worried about all the poor school children going without their drugs? I'm sure someone...
I want to be discharged.
I'll get the forms.
So there's some reality to that there. And this gets to be a very touchy area in medicine. And the first thing is that you can't hold patients against their will. They're allowed to leave. That is unless they are mentally incompetent or unsound or unsafe to leave. And that means that if someone, for example, couldn't walk or they couldn't avoid the environment if you're sending them outside to a snowstorm and they wanted to leave, you can't just do that. You have to make sure that they're safe. But if he's not mentally incompetent and he wants to call a friend to come get him, he could check out right now and leave the hospital. That's called against medical advice, or doctors frequently refer to it as AMA. The one thing that was not realistic about that scene is, as a doctor, you have a responsibility to try to explain to the person why they need to be there, what the risks could be to their health and life. You also have the responsibility of telling them the truth. You can't scare them into doing something that you want. And it sounds like here they're trying to use a scare tactic of a long time in the hospital to get something they want. And then immediately when he says he wants to leave, they're like, okay, great, let's get you the forms. And that's not very realistic.
His friend brought him in 15 minutes ago. Temps 105, pulse is weak and thready.
He's not making any sense.
It's too much money, Eddie. It wasn't the deal. It wasn't the deal.
Is he gonna be okay?
Eddie!
We gave him antipyretics and soft steroids to reduce the fever and prevent organ damage. He's no longer delirious.
Patient went out, came back worse than before. Points us back to...
So they have really, with this television show, they have made this a convoluted case where we have someone who first came in that sounded like there was a gunshot around them with powder on their arm and a head wound, to then noise made them pass out, to then what appeared to be almost a seizure in one scene, who then they were studying for nerve tumors. Then they started thinking about environmental toxins, and now he's got a fever, whoa, what do you know, of 105. Wow. I mean, are we dealing with meningitis here now, an infectious source? The next thing they're gonna do is do a lumbar puncture on him. This has really gotten bizarre. It also could be drug related. In fact, you can get very high fevers from drug associated ingestions. For example, if a cocaine baggie or something had ruptured inside of him, he could get hyperthermic. There are also certain medications, like even stuff as simple as like antidepressants, SSRIs. You can have certain syndromes associated with them, cause very, very high fevers. So this could be medication-induced, could be drug-induced, could be infection-induced. And again, we're at about our 6th or 7th Avenue here, so they've done all they can do to make this scene last a long time and be interesting, and probably, if you're a layperson watching, very confusing.
No, it doesn't. Where's Foreman?
He had a meeting with Cuddy.
What do you mean, no, it doesn't? We screwed up the tail. My car was impounded.
True, amusing, and irrelevant.
You're off environmental?
Wherever he went, it wasn't for long enough. Add in the fever, and infection's way more likely. And if it is an infection, his symptoms suggest it's moved to his brain, which means
Do a lumbar puncture.
Oh, lumbar puncture, we called that one.
It's not an infection, but it might be an autonomic nerve disorder.
the hair's still bumping. Did you get it cut because you're ready for the next chapter, or?
Stuck a needle into his spinal bodies twice. His heart rate stayed normal. If we add that to his other symptoms.
That would be a mistake. You're a wuss.
See that one? I'm better.
Are you gonna beat me up? It sounds stressful. Maybe you should pop one of your beta blockers first.
Okay, stop. Oh my gosh, this is why I don't watch these shows. So they went and did a lumbar puncture. We immediately had back results that said he's not infected. But one of the things they, quote, used as their differential diagnosis here was that they had missed as they were doing it, meaning, so you do a lumbar puncture, they're vertebral bodies that sit on top of each other. And you shoot in between those vertebral bodies to get into the spinal canal. And if you don't have the angle right, you can kind of start in the gap and then you can hit the vertebral body above or the vertebral body below. It's kind of tricky because it's not exactly straight. And so they had bumped the vertebral bodies going in. And because his heart rate didn't shoot up drastically, they determined there's something else going on. That's not accurate. People's heart rate will jump up with fear, with pain, and so on and so forth. This guy has already had plenty of it. The likelihood that missing on a lumbar puncture was going to change his heart rate enough that it was going to help you diagnostically is not realistic. The next thing is the doctor walks into the room here and says, tell me about your beta blockers. Okay, what are beta blockers? Beta blockers are a medicine used for blood pressure, used for heart rate control. And what they do is they keep heart rate slow and blood pressures low for the most part. You may have heard some of these in your family like labetalol or atenolol or metoprolol. It's all those alols. Those are beta blockers. They do blunt the heart rate effect. Frequently, people will use these. Some famous people use them to give speeches. If they're going to get really nervous and their heart rate will start to go up and they start to get sweaty and clammy and stuff, taking a beta blocker just keeps your heart rate just the same, nice, cool, steady, calm. And so the doctor here is saying you're beta blocker because he thinks that maybe he's taking this medication that is, one, keeping his heart rate low when they were bumping the vertebral bodies. Again, that's unrealistic. But two, the beta blocker could result in syncope or fainting, that dropping of the blood pressure that resulted in him passing out. Now that's a long ways from that noise-induced passing out that we saw to start this entire scene. But that's what this line of questioning about beta blockers is. So let's see where this goes, as unrealistic as it is.
You have a heart problem?
Medically, no. He would have told us about that. Metaphorically,
It's an effect from operating outside of the law. You know, sometimes I have to do bad things, and not always to bad people. The last few months, that hasn't been so easy. You know, a guy got me the pills, and they control the stress.
I think he's admitted that he's taken a beta blocker and that he got the pills from someone to control the stress. That part is not accurate. If you're gonna take a pill to control stress because you're doing bad things to people, you might take something like a benzodiazepine, that is like, you know, diazepam, temazepam. You may have heard the kind of the common lay names, or Valium. Those would be medicines that you'd be using to calm anxiety from high stress conditions like that. You wouldn't take a beta blocker for something like that. Beta blockers, the only reason they're used for things like speeches is because they control heart rate. When they control heart rate, you don't feel your heart beating, and then you don't start that kind of nervous cycle. And so you wouldn't take a beta blocker to control anxiety associated with doing bad things to people. That's certainly not reality.
Don't say anything to Eddie, all right? The last thing I need is the guys thinking that I've gone soft.
when was your last pill before we originally admitted you?
The night before.
And we stuck you in here and you went into beta blocker withdrawal. That's what caused the hypertension. When we got out of here, he took another pill and the hypertension went away. Which means it was never a symptom. We take that off the table, we've got vertigo, fever.
Stress. He's been in this game for a while. Either he grew a conscience over the last few months or he's producing excess.
Now, one thing that is true here at this point was they're mentioning that this patient, or I guess where we are now, is that the patient had taken beta blockers to control this anxiety associated with doing bad things to people, as you heard. And when he went off, he had some sort of rebound hypertension. That can be true. It's why doctors tell patients, don't stop your medications abruptly and talk to a doctor before you discontinue them. Because if you go off something that's keeping your heart rate suppressed and your blood pressure suppressed and you go off it suddenly, you can have these rebounds. So that part is true. It sounds like he had this rebound event that they documented as high blood pressure, and that solved one part of this problem for them. Now, just as I froze the video, we heard the doctor, I think his name is House, say maybe there's some pheochromocytoma. Now, pheochromocytoma is extremely rare, and this is definitely one of those teaching topics that you use only with residents to quiz them. And it's a condition where the body has like a tumor that releases excess adrenaline, excess stimulant, chemicals within the body, so to say, your natural neurotransmitter biochemicals within the body. And it does result in hypertension in patients who have it. It's extremely rare. I'm not too sure exactly how we're getting there, but let's see where this goes. I just heard the word start.
Chromocytoma.
What?
It's Greek for you'll be back doing bad things to good people in no time.
No, it's not.
You're okay with that, right? You're not gonna put a pillow over his face.
That was a lot of fun. Unfortunately, we never really got the answer there, or maybe we did. If one way or the other, there were a lot of inaccuracies there, but they did bring up a lot of medical topics that are very interesting. And the one thing I would say about that entire series there that was realistic, and it's any patient that comes in with a complex problem, in this case it started like syncope, passing out, you as a doctor start with a differential diagnosis. Try to determine what's going on, what's causing it, rather than just treating what happened. That's what, they could have just treated what happened here, which was the laceration on his head, and he'd have been gone. But as you see, it then ran through a bunch of things from seizure to hypertension, just a variety of different areas they went there with that. That part is real as far as the looking for that differential diagnosis and figuring it out. In this case here, it sounds like our conclusion, although not very rewarding, is a drug dealer who tortured people for probably not paying for their drugs, who couldn't stand himself, so somebody gave him a beta blocker. Again, I know we're getting unrealistic here, to help control his feelings of anxiety. He then couldn't take his beta blocker because he was in the hospital. That caused him to get high blood pressure. That part's fairly realistic, which then had them chasing all of these weird things to cause high blood pressure. He then stepped out and took a beta blocker. It sounds like he left briefly and came back in. Then he got back under control again. And I think that's where we left. The Dr. House there at the end threw in the big word pheochromocytoma, but then made a little humor out of it for what it actually stood for. People they're just gonna stop doing bad things to other people. Interesting, I had a lot of fun doing that. I hope I was able to clarify some stuff and I didn't interrupt the scenes so much there that you weren't able to kind of track along. Thanks for joining me.